I'm so happy to see you all here. Yesterday I tried something in Bali and I read it. I tried to speak in Bahasa to say hello. Okay, so I'm gonna try it. I was memorizing back there, like, okay. So, gonna go very slow, okay? Halo semayang, nama saya Dr. Alejandro Montoya. Saya Seman sama sama Beranda di City. Yeah, not bad, right? Thank you. I'm very happy to be here, and I will try to speak more in Bahasa. I will have some homework. So, and if my hair is falling, if I go like this, please tell me if I need a hair implant here, please. So, let me know. My topic today is beyond the algorithm. Any of you know what an algorithm is? Yeah? Using artificial intelligence, maybe? No? Not much? Okay. I'm going to explain you about algorithms today and why what one smile is doing is going beyond that. Oh, the clicker here. Oh, this is me. This is my beautiful family, my wife, my son, Julian. This is my favorite soccer team. It's the best. I love soccer. And actually, my wife is expecting. So I'm going to be a father in February. Thank you. Yeah. I'm going to be a father of two under two. So I've been joking around with all the doctors that I'm gonna be having jet lag, but permanent jet lag, like all day long, all year long. You have a beautiful country. I think that I've gained some weight eating pork and beef and rice and everything. But I wanted to show you also my country. This is Costa Rica.
I used to stare out the car window and pretend that I was flying. There was no car, no road, just me darting in and out of the trees, over the hills, over the streams. Let's just stare out the window for a while.
anytime happen to be near Costa Rica, let me know. And we'll have some coffee. We can review some cases together. Or we can go to some beaches, enjoy also. So yeah, that's part of who I am. And I'm very proud to be from my country. I know that you also feel very proud to be from your country as well. About me, really short. I studied in the University of Costa Rica, dentistry. So I was a general practitioner before becoming an orthodontist. And I got my degree from the University of Science and Technology, Latin American University of Science and Technology. And yes, I worked for Invisalign. Uh, Only for 10 months, I would say. But I was very happy there, to be honest. Actually, I was part of the Invisalign Pro program. That basically, that program, you connect to doctors from the United States and Canada to provide education. So the reason why I'm happy that I have worked for Invisalign is because I'm here now. So, and I will try for us to get into this hour or 45 minutes to learn together, because this is what I love to do. So, beyond the algorithm, what's up with the technology? So, I know that Matt already asked the question that how many of you have treated with aligners? But basically, when you're filling a prescription form, right? Because we are filling a prescription form for all the companies, we are telling the company how we would like to resolve the case. For example, if I have crowding in a patient, right? I could procline the teeth, I could expand the posterior teeth, or do some slicing, IPR. I'm going to say slice. We can do some slicing, right? Or the anterior-posterior relationship. I want to turn my class 2 into a class 1. I could distalize, I can extract teeth, I can use elastics, right? Those are the type of decisions that we are taking every single day with our patients. So I worked for Invisalign, and I was able to see their internal software. Actually, their internal software is called Treat. And the Treat is using your prescription forms, right? And it's turning your prescription into a treatment plan. Actually, the technicians that work for Invisalign and all the other companies worldwide, they have a special option that is called Final Position. So they click on that, and they have the case ready for you. But if you have paid attention, I haven't mentioned anything about your photographs, extraoral photographs or intraoral photographs, no x-rays, nothing has been taken in consideration. Only your prescription form. And we tend to do the mistake of approving the case like it was sort of like a video game, right? And we approve the case. I will try to convince you today that there's something beyond that. And as a treatment planning company working and partnered, being a partner of OneSmile, my goal today is to show you that there's a different way of doing things. Yes? Now, there's a lot of information nowadays. We can have this, and if you go to your favorite search engine and you type the word aligners, thousands of articles are going to appear in your screen. Because now we are able to see information about the cortical bone, the trabecular bone, the periodontal ligament, and all of this could be integrated. Also, the x-rays could be integrated. Your scan. We have now information about the material properties. We have now information about the thickness of the aligner, about the gingival height, about the trimming. And this could be built into a biomechanical 3D simulated model. You could be thinking, but this guy was talking about going beyond the algorithm, right? And I'm talking about algorithms. Well, it's true that the artificial intelligence could let us investigate and learn about the different movements before even get to our patient. We could be seeing information about extrusion, tipping, and we can build a database. But guess what? All of this visualization of biomechanics is just this. Guidance for the clinician. We are in 2025, and I like to believe that the artificial intelligence and all the things that I have mentioned are just to help us do our job. Because we still have hands and we still have a brain, right? So I'm going to show you cases, and I always encourage doctors to challenge us as a treatment planning company. Ask questions. Investigate. Because there's more things behind, there are not only things behind the screen, but you're the treating doctors as well, right? Now, I know that Matt already mentioned about the STL files. I have to be honest, and maybe you're thinking it now. The first time that I listened about smart STL, is the patient going to scan in the house without me, the doctor, in my chair? And I thought that it was impossible. No, these guys are joking. But I now believe in this technology, and I see the benefits of it. Have you seen this movie? Yeah, Back to the Future. Yeah, I was feeling like the movie Back to the Future, but in the future part. So we could integrate this technology. How many of you think about your patients before going to bed? Can you raise your hands? I think about my patients, right? It's very common. Or maybe when you're eating lunch and that composite. Yeah. Oh, that bracket, I know that tube on the 7 is, it wasn't that clean, you know? It happens. And I like to believe, or I like to live in a world where I'm going to bed and sleep all night, right? So it will be like sailing into open waters in a sea that is calm, and I can navigate. You know, I could navigate like this if I know where I'm going. But when we're treating aligners, sometimes we see a little space on the lateral incisor, little gap. And we tend to think, it's going to be okay. I'm going to switch to aligner 9. It's going to look better on aligner 9. No. I'm going to switch to 10, maybe. It's going to look better. And sometimes it could be a storm. We could be getting into a storm because I lost my direction. I lost my path. And maybe we could see it in a graphic now. You can see in the orange line the planned tooth movement there. And if there's an error, how that error could be increasing not only in millimeters, but also in weeks of treatment plan. That's exactly what the technology of and the integration with dental monitoring is doing. I'm not a speaker of dental monitoring, but I believe also in the product, and I believe in the integration that is happening with OneSmile. Doctors, engineers, and artists, dentists, that's who we are. That's how I feel, actually. I hope that you feel the same. About the Smart STL, we can be talking about the pros. We could be reducing the visits of our patients, improve compliance. If there's no green light, the patient is not going to move on with the aligners. Early issue detection, and I'm not talking only about orthodontics. I'm talking about hygiene. I'm talking about restorations that could be changed. And the flexibility that I can have my patients here in Indonesia, but also in Australia or in Bali, right? And the cons, it will be the cost, the learning curve, to standardize the process, but guess what? This box already has everything here. And the OneSmile team is going to be working with you here, side to side, deciding if we should be moving on with our patient or if mid-course corrections are needed. Let's see cases. Who is ready for cases? Yeah, me. I'm ready for cases. So what do you think about this woman here? Class 2, Division 2, yeah? We're having a retroclination of the upper teeth. Let's talk about the upper first. We have the canine in a crowding, maybe outside the arch. What do you think about the lower arch? So we have two premolars almost outside the arch. How much is the mesiodistal width of a premolar? 7.5, maybe? 8? Yeah? So if we start thinking or measuring that discrepancy, how much discrepancy do you think that this patient has? More than 5? Definitely, right? More than 10 millimeters? I would say so. More than 15? More than 15. So let's see what this brand of aligners did for this patient. So again, clinical conditions. Retrocline upper anterior teeth, class 2 division 2 patient. Full class 2 canine on the left, full class 2 molar on the left. There's the retroclination. And when we go deep bite, and when we go to the lower arch, we see the amount of crowding. And you could be thinking, Doc, but I have maximum IPR there. I should be safe. I'm going to play the animation now. Let's activate the superimposition here. How many millimeters of proclination is this patient having? Let's count. 1, 2, 3, 4, 5, 6, 7 millimeters of proclination of the lower anterior teeth. How many of you have 7 millimeters of cortical bone? How many? Well, we are not watching cartoons. The animation and the video of the treatment plan is not like watching cartoons. Is the way that the plastic is going to move to have a result in our patients. And this is the result this woman had. Do you see the roots there? I can see the roots there, right? And you might be thinking, oh, but the crowding is resolved. Do you think the crowding is resolved? This is the second refinement. Whenever you don't have cortical bone and you're trying to procline more, there's no room to go. So there's a relapse of the movement of the lateral incisor. Let's see the third refinement. How do you explain to your patient that this happened? Just because you hit approved right away in the first treatment that you received. How many months do you think that have passed from the first refinement or the first treatment to this point? I would say that more than 1.5 years. And now you need to explain to your patient that it didn't work out? Let's take a look at this patient. Class 3. Edge to edge. Do you see mandible deviation there? I see a mandible deviation as well. How many of you would have compensated this case? Raise your hand. No hands? No? Any? No? I'm going to tell you why. You see that the canine is in a class 1, right? And there's some space there. I know that my patient is in a class 3 relationship in the molar. But you see that in both sides, I have a class 1 canine. I know that I need to beat the skeletal pattern of my patient. I need forces to help me close the spaces in the lower. Not only IPR, I need something else. Guess what? They didn't place elastics for this case. They didn't place elastics. So there's no way that I can beat the force of nature of my patient. I need to retract, yes, but see how the plastic retrocline the lower anterior teeth. And not only that, an interference was created, and now I have a posterior open bite. No context on the posterior. Is this what you want for your patients? Is this what you want for your practice? I'm just doing an honest question, right? And I'm going to ask you the same question by the end of the presentation. Maybe the answer could be different. There are some innovations that we're working on, and if you haven't treated cases with one smile, you're going to be pretty much surprised by the fact of how everything will change in the last months of this year. The first thing that we're going to have is the Smile Genie app, integrated into OneSmile. So it will be a great tool for you as a treating doctor, because we're going to be able to show the patient a simulation of how the smile could look like at the end, right? Having not only an orthodontic approach, but a multidisciplinary approach. Because many of the patients that are entering into your practice will need crowns, will need bridges, will need composites, we need prosthodontics. There are plenty of things that we can search or look into the photos. We can see the lip line and the relationship of the midline, of the lip line with the teeth. We can see the buccal corridors. We can see whether if I have an inverted smile or a gummy smile. And guess what? It matters. This is a very good article where they are evaluating a man who has the upper midline centered with the facial midline, and they ask people, deviating the midline to the left and to the right, and canting the maxillary arch, and they did a poll. And people responded that this guy is more attractive with the midline well centered and without a maxillary canting. So it matters. Is your current aligner brand taking this into consideration? Let's do cases. Let's review cases. This is a patient of mine. Back in the residency, this is my logo. I'm going to change it. I'm going to tell you why. Please don't make fun of me. First of all, it looks like fast food, right? It looks like McDonald's, right? And one of my teachers was looking at the logo, and she told me, "You know what, Doc? I think that your logo looks like the part of the body where you sit down." And I was like, okay, yeah, I might need to change my logo. But there it is, just to make the joke, okay? This is my patient, Carlos. Something doesn't look quite right with Carlos, right? When we take a look at the right picture or the smile picture, we see some spaces here. I see some crowding. I see a restoration of the central incisor. Profile looks good. And the chief complaint of Carlos is, I want to improve my smile. I want to look better. This was the chief complaint of Carlos. Beautiful class 1 on the right side. It's like textbook class 1. But I start to see some things that could be a concern for me. For example, I don't see the second premolar on the left side on the lower arch, right? I see some recessions also on the canine, the 2-3, in the premolars 2-4, 2-5. I don't like this restoration, right? It doesn't look like that natural. And there's the crossbite of the premolar. And I can see the recessions better from that occlusal view. Here's the panoramic x-ray. Every case that I'm going to show you is going to come with a panoramic x-ray and a cephalometric x-ray, because we are taking that in consideration to do the treatment planning. That's what Clear Forward is doing. Cephalometric x-ray is a class 2 patient. There's a mistake in the next slide. It's a class 2 skeletal patient. So I do the diagnosis of my case. Class 2 skeletal patient, class 1 molar and canine. I have crossbite of 1 premolar on the left side, missing 2-6, root treatment in 2-1, and recessions. Asymmetrical gingival heights. So I need to talk with my patient about the periodontal condition. You know, Carlos, do you have recessions? And I need to ask another professional, here the periodontist, Doc, I'm planning to expand the arches. Is it safe for my patient? Do I need grafts at the beginning or at the end? Should I use an elastic to correct the posterior crossbite? This is the type of analysis that we are doing for every single case. And this is the prescription form that you're going to fill whenever you're going to submit your next case of one smile. Who's excited to submit a case for one smile? Yeah? No? Yeah? Woo! Woo! In Costa Rica, we do la de. So, conditions of the patient: crowding, deep bite, flare teeth. You're going to also choose, like any other brands, if you want to change the midline, the overjet. And guess what? You're going to be able to write it down in your language, if that is something that you find more comfortable. So feel free to write down your instructions as you prefer. Whenever you know the road, you can see blue skies and everything green. So this is Carlos at the end of the orthodontic treatment with aligners. My recessions are still there, yes, but not worse. They're still there, but they don't look worse. I don't have crowding on the lower. I'm going to show you, maybe you can see there that the premolar has corrected the crossbite. And now I can see the gingival heights of the lateral incisors are even. And I need to do some work here for Carlos because I have uneven gingival margins between the central incisors. There's the premolar. I wasn't lying. We corrected by just pushing the premolar with the aligner. No auxiliary techniques. Just making the space. It's still a class 1 canine. Both sides. And I need to test some things with Carlos.
Foca, ferrocarril,
The F sound.
Fósforo.
F.
fa,
To see the relationship of the incisal edges of the upper with the lower lip, right? F, and also the S.
60, 61, 62,
60,
63,
to see the vertical dimension.
65, 66.
And also evaluate the overjet of my patient. And then I could start doing my mock-up, my restorative, the preparation for my restorative. Look how Carlos looked like with only the mock-up. I was very afraid of this appointment because I thought that he was going to run with the mock-up and not return to the clinic. Yeah, right? What like sometimes happens with the provisionals. Preparation for the veneers, testing. And this is how Carlos looked like with the veneers. Ortho restorative treatment plan. Testing it with the black light. Beautiful class 1 still. Before and after. Before and after. Before and after. He looks like Clark Kent. Before and after. We're also changing the software with the one that we're doing treatment planning for you. This is an actual video of one of our orthodontist team members who are doing a live staging of a case. It takes a lot of work to do a staging. Actually, for this clinician, it took like 15 minutes, and we're going to watch the entire... No, we're not going to watch. We're only looking at fast forward of that staging, right? But more to come about this. Also, we're going to have a CVCT integration. So whenever you need to evaluate a canine in an ectopic position, a missing, impacted canine, thin periodontal biotypes, we're going to have this integration. Also, we're going to have integration with twin blocks. Are you familiar? Have any of you used twin blocks in ortho treatment? Yeah, you, Doc? Yeah, great. They're great, right? In growing patients, they work wonderful. And now we have a technology with aligners, which is very good. Let's take a look at a very quick example about mandibular advancement, just for you to get excited. This is a twin block. It's like the granddad of what now they're using with aligners, right? This is a patient, a class 2, division 1 patient, retrognatic mandible. Let's take a look at the clinic. Oh, sorry, I was about to mention that not every patient should have a mandibular advancement. Actually, we're doing an evaluation of the cephalometric X-ray because the patient should be on a stage between CS3 and CS4. We're doing this evaluation for you. It's part of our treatment planning service. Class 2 Division 1, let's see the big overjet that the patient had. The doctor forced the patient into that new position to see if it was possible for the patient. So he manipulated the mandible, right? To see if for the patient was able to do that advancement without any type of pain on the temporomandibular junction. These were the results. Is now a class 1 patient. Even is class 3 on the left side. So, mandibular advancement is something that works. But I want to show you a one smile case, right? Because I'm talking about one smile today. What do you think about the mandible of that young patient? What do you think, Doc? How do you see that mandible? What do you see? It's retruded, right? Retrognatic mandible. Do you maybe think that it's because of the crossbite that maybe is limiting, creating some limitation of the growth of the mandible? It could be, right? Maybe. When I take a look at the panoramic X-ray, I see that the sequence of eruption is not that bad. Actually, it's quite good on the lower. And on the upper, what I see is that I might be struggling a little bit with the space for the canines. Right? Here. It seems like a class 1 patient for now. I don't have the numbers of the cephalometric X-ray, but it looks like a class 1. And this is the treatment plan that we did for this doctor using one smile. 25 aligners. 25 aligners, it will be like 6 months of treatment, right? Using like a 1-week wear. So look how stable it is, the bite on the posterior. So I always tell the team, whatever is right, do not mess with whatever is right. Let's try to resolve the chief complaint of the patient first, and then the clinical conditions that need to be solved, that need to be resolved. So mainly, we resolve this case with expansion. Expansion to create space for the permanent teeth, expansion to correct the crowding. And this is the result. What do you think about that result? Do you see the mandible now? So maybe you think that we are kind of magicians, creating mandible, creating bone. Actually, no. We are letting the patient grow. By correcting the crowding, the mandible was free to grow. So we guided that growth of the patient with clear aligners. Don't you find that amazing? I kind of love this case. You will treat the next success story. I believe that any of you could be treating cases like this. I'll be happy to share, whenever I'm back, cases from all of you. One smile also for crowding corrections. Asymmetric class 2 patient, anterior crossbite. Again, let's plan. 33 aligners. Class 2 asymmetric malocclusion. It was on the right side. We had that class 2 canine, because look how stable it was on the posterior teeth. 33 aligners, expansion, use of proper attachments. Let's see the staging. See how we are doing the rotation of that lateral incisor at the same time that we're proclining the upper teeth and expanding. We are creating space. Every time that you submit a case for OneSmile, you're going to receive information about the IPR, you're going to receive information about the attachments, you're going to receive information about the clinical considerations. And the clinical considerations are vital part of the work that we're doing every single day. Basically, we're telling the doctors, doctor, you need to be careful with this. We recommend you to apply the IPR from the beginning. We decided to place this attachment because we think that it will be better for the patient. Please monitor the periodontal condition of the patient, since we are proclining, not like the first case. And this is the result for this patient. You might be thinking, oh, but this is not the perfect class 1. She had a Bolton discrepancy. But if you notice, if we perform some little IPR on the right, we could even move the midline to the right, and resolve the case. 33 aligners. Oh, so how did I come back? Let me come back. Okay, this case. What do you think about this woman? Anterior crossbite, premolar out of the arch, bridges all over the upper arch on the posterior. On the lower, we also have crowns. Sorry, let me go back. We see the restorations here. The bridges here. So instead of saying to the patient, I think that we cannot do anything for you, let's plan. Let's plan first. So I need to think, how can I create space for the lower arch crowding to be resolved? I'm not going to procline 7 millimeters like the first case that I show you. We need to extract a premolar to create the space. And the crowding will resolve itself by just using the space that we created. If we need to correct the anterior crossbite, I will use bite rams to lift the bite and let the movement happen. You see how it was easy once that I extracted that premolar to create space for the lateral incisors. This is the patient now. The profile looks the same. Good smile. And this is the result. No anterior crossbite. Black triangle here. Yes, it was a black triangle there. It had a very serious crowding. We could do a restorative approach now to close the black triangle. But look at the stability of the case still. And the doctor requested to intrude the posterior segments because he was going to change the bridge on the quadrant 2, and he was doing some restorative work, some onlays on the quadrant 4. This is the result. No refinements. Let's dream about the world without the word refinement. I think that with OneSmile it's possible to do this. Nice case, right? Yeah. How about this one? Bridges everywhere. This is the initial condition of my patient. This is from a patient of mine back in Costa Rica, actually. And he was like, Doc, I trust you. I want my mouth like when I was 20 years old. Okay? Okay. Let's see how can we do. Closer look. Bad restorative there, right? Take a look at the asymmetric arches here. I have 2 premolars in the first quadrant and only 1 rotated premolar. So if I want to do something, I need to deal with that asymmetry. I need to correct it. I'm going to take some water, sorry. This is Joseph. And this is Joseph at the end. Maybe not 20 years old, but close, right? And this is the new restorative for Joseph. We extracted the first premolar on the left side. Class 1, a stable malocclusion on the posterior. How beautiful the arches look like now. Diagnosis, happy patients, happy life. Let's talk about the importance of the staging. Staging is very important. For me, it's like the foundations of a house, right, of a building. So we have movements that go well together. For example, I could expand and retract the anterior teeth at the same time. I can distalize and torque. I can extrude the posterior and intrude the anterior, or the other way around. This is what we're taking into consideration when doing the staging of your plans. Because there are also movements that don't go well together. Like this. Expanding everything at the same time, intruding everything at the same time, extruding everything at the same time. There is also microstaging, doing rotation first and then extrusion. If we are going to do some root torque, intrude at the same time. Derotation and expansion, for example. Dividing the movements. I'm going to first intrude, correct the crossbite, and then extrude. This type of tricks are not in the books. We need to analyze case by case. You cannot apply the same for every single patient. We need a customization of the plans, which OneSmile is doing. And I asked ChatGTP, because he's my friend, my personal friend, the concept of anchorage. Do any of you know the concept of anchorage? Yeah? Yeah? No? Maybe we will have this for the next time. But basically, anchorage is a word very important in orthodontics, because when we are extracting teeth, we need to understand how we're going to close that space. It will be like movement of the molars. It will be a reciprocal movement. It will be just by retraction. So more to come about that anchorage topic. I want to see more cases. I kind of feel that the vibe that we need to see more cases here. Let's see a distalization case. Convex profile. Retroclination of the upper anterior teeth, upper centrals. Proclination of the lateral incisors. A skeletal class 2 division 2 patient. Full class 2 canine, full class 2 molar, both sides. Constricted arches, deep bite. There's the cephalometric x-ray. The mandible completely trapped behind the incisors, right? And this. Third molars. Very important for a case like this. Very important to evaluate the third molars. I'm going to tell you why. Let's begin with the end in mind. This doctor specifically requested, and you can see in the notes, the patient would like teeth straighter, does not want any extractions at all. And I'm going to do a little pause here. If your patients are coming to your practice to dictate your treatment plan, that's a red flag for you. You are the treating doctors. You're going to be the ones calling the shots. It doesn't mean that you're not going to take in consideration what the patient is saying, right? But if for the patient it's better to have extractions, you as the treating doctor are in the obligation to recommend what is best for the patient. So this patient didn't want any extractions. But if I have a class 2, division 2, I could distalize or extract the fours, right? The first premolars. So maybe the answer for the patient is, okay, I'm not going to extract any premolar, but yes, the third molars. And I'm going to show you the case. Class 2 elastics with distalization, very important to use them, because if you see these models on this side of the screen, when we are not using elastic, everything is moving like this. Not only intrusion, not only distalization, that is what we need, but also intrusion, mesialization, tipping, and whenever we are using class 2 elastics, we are directing more the forces towards the distalization. And this is the case that we did for this doctor. It's like making a line in the grocery store. You cannot advance if someone is right in front of you. It's the same that happens with teeth. So, again, synergy of movements. I cannot move everything at the same time. So, I need to move my sevenths, my second molars first. You see how beautiful it goes. Second molars, first molars, then the second premolars, then the first, then I go with the canines, then my laterals can come in, and last, I can procline my upper anterior teeth. It's like a dance. It's like dancing. And the reason behind this is that I cannot move my teeth whenever there's no space to move them. That's the reasoning behind. That's understanding the plastic. I guide my team to use scientific evidence. I'm not trying to convince you today to use Alejandro Montoya's method. I'm telling you that we're taking this type of information in consideration. For example, it says that only 33% of the intrusion with clear aligners is actually being represented in our patients. Only 33%. Because it's one of the most difficult movements to achieve. It means that overcorrection is needed for the patients. So if I want to achieve 2 millimeters of correction, maybe I need to add 3. Using the smart STL and dental monitoring, that will be very much easy because you're controlling it, you're seeing it. Let's see this patient. Biprotrusive patient. Class 2. Crowding and deep bite. Let's concentrate on the deep bite. And remember these pictures because I think that you're going to be amazed by the results. Let's go into the plan. Panoramic X-ray, again, not the best. It's kind of elongated. Cephalometric X-ray. We see a proclination of the upper teeth. It's a class 2 patient. And let's see the plan. 40 aligners. I'm not that good at math, but how many months? 6, 4, 40 aligners, yeah, 10 months, right? Look at the deep bite of the patient. It was a deep bite of almost 80%. And this is what we're planning. Proclination of the lower anterior teeth. Whenever you have a case that is crowded, if you add proclination, at the same time you're prescribing relative intrusion. So when you have a deep bite with crowding, very good news for you. Because you can have not only pure intrusion, which is very difficult, but you can have proclination and relative intrusion at the same time. This is the result. Very good on the facial, right? Looks the same, I would say. Nice smile. And this is the correction of the overbite. So it went from 80% of overbite to 20 in 10 months without the word refinement. No crowding here. Technology built into the plastic. Treatment plan optimization. Pretty cool result. I'm going to jump this one. It's a very good result because I want to get the information from Sheldon. I know that you're going to find it very valuable. Let me jump this case. Sorry. But you see, very good case. One small works. This is the last case that I'm going to present. So we have this girl, right? Gummy smile, procline anterior teeth, upper anterior teeth, crowding, huge overjet, not that much crowding on the lower. So if this patient comes into my practice to say, I want to fix my proclination, but I don't want the extractions, doctor, I will give the card of my colleague across the street. Because it's not possible, right? That's why we are helping One Smile doctors. Because this type of cases require diagnosis. If the patient wants to correct the proclination, this is a case for extractions. And we prescribe extractions of the first bicuspids on the upper arch. The gummy smile is due to a vertical excess of the maxillary bone. Vertical excess. So we need to have a conversation with the patient. You know, we're going to resolve the crowding, we're going to reduce the proclination, but the gummy smile is going to stay the same. Because your problem is skeletal. And this is what we can resolve. Diagnosis. Again, all the parts of the notes that you're going to receive. Diagnostic, means of treatment, and the clinical considerations. Doctor, we are extracting, and we're also asking you every time that something special is needed. We are recommending the size of elastics. We're recommending the wear time. We are providing all of these notes with the treatment plan. And this is the plan. Again, class 2 elastics to avoid loss of anchorage. It's a class 2 molar, right? So if we extract the first bicuspid, it means that it will end up in a canine class 1, but a molar class 2, right? That's expected. And the reciprocal space closure is going to happen. Why? Because it's the most efficient way to close the space for this patient. So it will be like this. Okay? 30 aligners. Again, there's the overjet. How much overjet? I would say that more than 10 millimeters of overjet. Let's play. Slower. Here it goes. Reciprocal space closure. Sequential mesialization. Predictable ways of resolving a case. It's like playing Tetris. And I know that I said that at the beginning that it's not like a video game, but this is one of the good ones, right? It's like putting the pieces together. If there's a piece that is not matching, it's because maybe you need to go back to the diagnosis. Something is missing, maybe. Oh, sorry. What happened? Ah. Spoiler. And here it is. After 30 aligners, almost all the space has been closed. No proclination of the upper and anterior teeth. Class 1 on the left side, class 1 on the right side. No crowding on the lower. The gummy smile is the same. We already talked about this at the beginning. 30 aligners. One smile works. It really works. So I'm going to ask you again. Is this what you want for your patients now? Is this what you want for your practice in ortho? The results that we just saw about different clinical conditions, class 2, class 3, kids, deep bite. Final slides. The bonus track in Matthew was mentioning, we could do a scallop treatment, a straight trim line above the gingival margin, and guess what? Every single thing that I've just mentioned matters. There's the proof. Extended trim lines could work very well when doing torque. Scallop trim lines with correcting and crowding. The evidence is there. Let's use it. The next talk and the next time that I'm going to be here, I'm going to be here again. It's going to be about the integration of clear forward dental monitoring under the roof of OneSmile. So it will be called OneSmile Synergy Treatment Optimization and Monitoring in one system. So I'm very excited for you to use the product to power that database of dental monitoring, because we're going to be showing cases here live about how that integration went. Use your smile to change the world. Don't let the world change your smile. This is my LinkedIn. If you want to follow me, I'm going to be posting more content, clinical content. I would love to hear your feedback about the lecture. I really had the greatest time in Indonesia. So, terima kasih. Any questions? Questions? No? Yeah, you have one? No? Any questions? No?
Apakah ada yang mau nanya, Dok?
You, Doc? Yeah, go ahead.
Sebentar.
Sorry, I just want to ask the possibilities of relapse. Is it how much percent?
Thank you so much for that question, Doc, because it depends. Basically, when I don't know if you noticed that I was talking a lot about canine class 1, right? So when we have a canine class 1 at the end of the treatment, we are having a very stable result in preventing the relapse. And I'm going to tell you why. Because when we have canine guidance, we are able to do lateral movements like this, right? To the left and to the right. And that lateral movement is providing protection to the posterior teeth. It's like in a stable position, a natural position of the teeth, right? Whenever we don't achieve that, and there's a huge overjet, for example, or anterior context, that's not a stable position for the patient. So in order to prevent the relapse, one of the first things that we do is to provide a canine class 1. Now, I have some bad news to all. The relapse also depends on the patient, right? For the patient to wear the retainers, basically, to wear the retention. And scientific study says that in the first 6 to 10 months is where the relapses are happening. So good advice that I will give you is to tell your patient you need to wear this at least for 8 months, 24/7. And then you can switch to nightwear. I've seen the retainers from OneSmile actually, and they're really good. Very good technology, and Matt can comment about this, more about the guarantee and everything, but I don't know if that answered your question, Doc.
Pardon?
Yeah, did it answer your question? Yeah?
Sure. Yeah.
Yeah?
But if retainer can help, perhaps
Yeah.
for maybe years, 2 years, or 3 years, or how long?
We put a 10-year guarantee.
Oh, about 10 years.
10-year guarantee on our clear aligner cases. So what Dr. Montoya is saying is patients post-active aligners should wear their retainer
Okay.
every day, 24/7, up to 8 months.
Oh,
And then night wear, malam wear,
okay.
after that. We put OneSmile
For 8 months.
8 months
Okay.
full time, like wearing a liner, but,
After that?
but passive.
Okay, after that?
After that, nighttime wear, and we recommend for as long as you can,
I see.
because retention, if you're a good orthodontist and a patient asks, how long should I retain my teeth for? The response should be, how long do you want straight teeth for? Because yes, there won't be as much relapse in 1, 2, 3, 4, 5 years, but we want to stop relapse. So, Budi, do you want to communicate in Bahasa our 10-year guarantee, or Ken?
Ya,
Ya.
selamat sore dok.
Sorry. Maaf.
Yeah.
Ya, jadi di Westmail itu kita ada beberapa paket dok. Jadi yang paling dasar adalah paket Express, itu berdasarkan jumlah linernya. Express itu ada sekitar 10 set liner, kemudian di atasnya ada light 20 set liner, di atasnya lagi ada moderate 30 set liner, kemudian yang paling banyak dokter suka adalah komprehensif paket dok. Jadi dia itu unlimited liner, kemudian juga setelah selesai kita ada garansi selama 3 tahun. Jadi meskipun dokter sudah pakai retainer, kalau misalkan pasiennya itu relapse lagi, maka itu bisa kita buatkan lagi dok. Seperti itu dok. Jadi 3 tahun itu dari pertama pakai sampai 3 tahun ke depan. Nah yang paling atas kita ada garansi 5 tahun. Seperti itu. Nah paket kita itu semua itu sudah termasuk 1 set retainer di belakang. Kayak gitu dok, itu paket kita dok. Ya. Sudah?
Okay. Very fast Bahasa.
Anything else? No? Yeah.
Mau nanya pakai bahasa Indonesia juga boleh, nanti kita ada translate-nya dok.
I think
Mungkin
the doc.
ada yang mau nanya?
I want to ask, what about group function?
Sorry?
Group function.
That's a very good question, Doc. We could have group function, whenever there's not possible to achieve the canine guidance. For example, and I would say that the group function works whenever we don't have the canine. There are certain decisions sometimes within the impacted canine, right, that maybe is in a horizontal position. So if we need to extract the canine and replace it with a premolar, right, in terms of the occlusion, the patient will be working with a group function. So I'm not saying that we cannot do group function, but whenever it's possible to achieve that lateral movements with the canine guidance, that will be our goal. But group function basically works on those scenarios that I can think of, right?
Will
Yeah.
it give a similar or on par stability?
I would say that it will be stable, yes, but the thing here is that with group function, there will be more work on the posterior teeth, right? So sometimes you can combine the treatment plan after the ortho with the splints, for example, because you know that the patient is already in group function, you know. Also, the group function works like this. The case that I show you with the extraction of the premolar on the lady with a lot of restorations, right? She's gonna work with group function, right? Because she has a lot of restorations. So my advice here is that whenever it happens, whenever we cannot achieve that canine class 1, to plan with the patient to have a splint in order to have protection of the posterior teeth. That's basically one of the goals of orthodontics, right? As you may be aware.
Thank you.
Yeah, you're welcome. Sama-sama, yes? Sama-sama. Anything else? Terima kasih.
Ada lagi dok?
Sama-sama. Thank you, Dr. Montoya.